Thank you for the invitation. My name is Ahmed Hegazy. I am a consultant intensivist. I currently work in Saudi Arabia in Medina Cardiac Center, and I also work in Canada. So I'm part-time in Canada. I travel back and forth, and I'm currently full-time in Saudi Arabia. So what I'm going to be talking to you about is volume responsiveness and volume tolerance and VExUS. So we'll cover these three topics.
Recording in progress.
And we'll talk about them one by one. And what I'll specifically try to cover is ultrasound for volume responsiveness, the concept of volume tolerance, which is a concept that a lot of us ignore a lot of times. And then I will introduce the topic of VExUS, which is growing in popularity and in use in the intensive care units. So let's start with ultrasound for volume responsiveness. The underlying premise here is that you are treating a patient who has hypotension, shock, or cardiorespiratory failure. I'm not talking about a normal patient who is asymptomatic with a normal lactate who's well perfused. I'm talking about a patient who is critically ill in the ICU or in the OR, who is hypotensive, in shock, or presenting to you in cardiorespiratory failure. And all the rest of this talk will be built on that prototype. And so forget about the normal patient who has normal lactate. Even if you find somebody who has signs of volume responsiveness on ultrasound, but they look like they're perfusing well, they look healthy, they look well, do not give them volume. Treat the patient, right? So if the patient looks good, then forget about anything else. What I'm talking about here is how to understand whether your patient is volume responsive and they're coming to you in shock. So hypovolemia means not enough blood in the thorax. We all know that most of our blood is in our venous reservoir system. 63% of our blood is in the venous system. And about 15% is in the arteries, and about 5% is in the small arteries and capillaries. There's about 17% that is in the thorax, and that I can point to here, that 8% in the heart and 9% in pulmonary circulation. When that amount of blood is reduced, that is when you start seeing symptoms of hypoperfusion due to hypovolemia. So that's about 17% of your intravascular volume is really the important part that, I mean, obviously it all is interlinked. It's all one circuit. So if you drop in your intravascular volume, you will see that reflect on your intrathoracic volume, definitely. So let's basically try to define what volume responsiveness means. So volume responsiveness means an increase in stroke volume by more than 10% after receiving a volume bolus, which we've defined as 6 mils per kilo, over 10 minutes. And this definition is based on a lot of the publications and a lot of the literature out there. It means that you get benefit from giving volume. It's the green traffic light that, yes, go, give volume. The patient will benefit from volume. The volume bolus that we will give will increase his stroke volume and will increase tissue perfusion. So this is volume responsiveness. It really means the patient will benefit from volume. On the other hand, so before I move on to volume tolerance, I just want to also show this curve that very clearly shows us that when you administer fluid to somebody who is volume responsive or fluid responsive, you see an increase in stroke volume that is proportionate to the volume that you've administered. Whereas if somebody's not fluid responsive and he's on the flat part of the curve, you'll give volume, but the increase in stroke volume will be very modest. And so this patient would not be responsive to volume. And so an increase in stroke volume based on a fluid bolus defines volume responsiveness. The patient benefits from getting the bolus. On the other hand, volume tolerance means that giving volume will lead to side effects, will lead to problems in the patient. The patient basically giving volume will lead to pulmonary edema, will lead to organ congestion, will lead to prolonged ventilation in the ICU, possibly prolonged ICU length of stay from excessive volume loading. So all of these are indications that the patient is getting harmed by the volume bolus. So volume responsiveness means they're getting benefit. Volume tolerance or volume intolerance means that they're going to get harmed from that volume bolus. And so these are two different concepts, and you should keep your eye on both when you're treating your patient. And I'll go through how you should keep an eye on both shortly. So there are indicators for volume responsiveness. There are indicators that are static parameters, and there are indicators that are dynamic parameters. And what I mean by static parameter, it's a point in time where you're taking a single measurement. That's what I mean by static. It's a snapshot in time. You're taking one measurement right now, and you're making your decision according to that measurement. When I talk about dynamic parameters, I'm talking about two measurements, a measurement before and a measurement after. And then you make your decision based on the measurement before and measurement after. This is called a dynamic parameter. When you talk about static parameters, things that come to mind include the CVP, our classic old friend, the IVC diameter, just taking an absolute figure for the IVC diameter and acting upon that, the left ventricular end diastolic area. All of these are static parameters. On the other hand, dynamic parameters, where you're taking two measurements, not just one measurement, it could be taken with an external fluid challenge. You could look at your dynamic parameters with heart-lung interactions, with passive leg raise. So what I'm referring to here is measuring the cardiac output or the stroke volume before and after an external fluid challenge. That's number one. Like before and after, or actually instantaneously during respiration. So that would be the heart-lung interaction, or a passive leg raise. So the heart-lung interaction or the passive leg raise are both called the internal boluses. You're giving the patient a bolus of his own blood with the heart-lung interaction and with the passive leg raise. The fluid challenge is an external bolus test. You're giving an external volume bolus and assessing your parameters pre and post. So these are called the volume responsiveness parameters. The volume tolerance parameters with ultrasound include left ventricular size and function. Obviously, we all know, if you've graduated from medical school, you know this as a fact. If somebody has really bad heart failure, a dilated LV, then you should be careful with volume. You may be giving the patient a volume bolus and causing them harm if their LV function is severely impaired. So you need to be judicious with volume administration if they have severe LV impairment. Same goes for the RV. If you have an RV that's huge in size, giving volume will only increase that RV in size, will lead to septal deviation, and will lead to harm. You'll reduce the left-sided filling if you give somebody with RV failure with LV distension a volume bolus. With RV distension, a volume bolus. So here, lung A and versus B pattern. So if you have a lung that's full of B lines, then giving volume to that patient will increase their congestion and will likely lead to trouble. And the last thing is VExUS, venous excess ultrasound, which is a parameter that indicates congestion with ultrasound of your abdominal organs. And we'll go through it shortly. So I want you to keep this in mind. This is the framework we'll go through in our talk here. Volume responsiveness parameters, static versus dynamic, and then volume tolerance parameters we will go through at the end. So let's start with the volume responsiveness parameters, where the patient may benefit from volume, trying to decide whether to give a volume bolus or not. So the static parameters, we'll start with the CVP. Now the CVP, it's an old friend that we all look at, we all know very well. And this famous graph here that was published by Paul Merrick and his group showed us the relationship of volume status to the CVP, and the dots are all over the place. So it tells us really that CVP is not a great indicator of volume status in and of itself, on its own, as a static parameter. And actually, what it shows here is that the correlation between blood volume and CVP shows an R value that is very low, and the positive predictive value for being volume responsive with a CVP of less than 8 is 47%. It's like flipping a coin. So will the patient be volume responsive? Might as well flip a coin. CVP power in detecting volume responsiveness is as good as flipping a coin. So mind you, do I ignore the CVP totally? No, I don't. In my practice, I still look at the CVP. I take it in context. I don't take it as the sole parameter for volume responsiveness, but it definitely is part of the picture. And especially if I have serial measurements, a trend I find is sometimes more useful as part of the big picture. But taking it on its own as a single parameter for giving volume is not really good practice. So IVC diameter is next on my list. What about measuring the IVC diameter and seeing if you're volume responsive based on that? So there's been lots of studies that have looked at the IVC, and I'll try to summarize them in the next two slides. But in summary, when you look at the IVC diameter, in mechanically ventilated patients, 70% of the time, it's not useful. And let's go through this here. So here, this is a study, the biggest study that they've looked at the IVC, where they've looked at the IVC, where they enrolled 540 patients. It was a French study. And they found that the IVC measurement was quite feasible in most patients. They found that if the IVC at end expiration is less than 13, it predicted fluid responsiveness with 80% specificity. If it's more than 25, predicted the absence of responsiveness with 80% specificity. However, what I want you to notice is that the number of patients where they found these numbers were actually around 5%. So out of 540 patients, they found an IVC diameter of less than 13 in 62 patients and more than 25 in 61 patients. However, in 71% of patients, they had intermediate values that did not allow predicting fluid responsiveness. So I'd say 70% of the time, the IVC is neither here nor there. It doesn't tell you volume will be helpful, or it doesn't tell you volume will be harmful. I'd say 71% of the time, it will be in the gray zone, right in the middle. And it will definitely be not reliable if you have a high intra-abdominal pressure. With high intra-abdominal pressure, the IVC is collapsed. And so this patient's treatment is to relieve the intra-abdominal pressure, not to give volume. In fact, giving volume to somebody with abdominal compartment and high intra-abdominal pressure will be detrimental. And so IVC diameter mechanically ventilated has been studied, and I'd say 70% of the time it's not useful. IVC diameter in spontaneously breathing patient has also been studied in about 9 studies, and I try to summarize them here. Responders mostly had a minimum IVC of 6 to 16. Non-responders had a minimum IVC of 9 to 19. A single IVC measurement is unlikely to be a good predictor on its own. So you need to take multiple parameters before you make that decision. So let's move on to the third parameter. And the theme here that I'm trying to impress is that dynamic parameters are usually better than static parameters, and multiple parameters are better than one parameter on its own. And that's basically what I'm trying to say in the next few slides. Let's look at the next parameter, left ventricular end diastolic area, as a static parameter. So when you look at left ventricular end diastolic area, the literature on that comes from anesthesiology publications. And they looked at the parasternal short axis view in the mid-papillary level. They freeze, they scroll to diastole, and then they trace the endocardial border in diastole. The normal left ventricular end diastolic area in normal subjects is anywhere from 9.5 up to 22 centimeters squared. If you have a left ventricular end diastolic area of less than 9.5, you're likely going to be volume responsive. And so you trace the endocardial border, as we see here. And if you find a very low left ventricular end diastolic area of less than 5.5 centimeters squared per meter squared body surface area, this suggests hypovolemia. Beware of suboptimal image quality, especially when you're interrogating inadequate images, when you have an endocardial border that's not very clear. Don't make conclusions based on images that are not ideal. I'd say one piece of information that I always tell the residents is no information is better than the wrong information. If you tell me I don't know, I respect that. If you tell me the wrong information, that can cause harm. And so I would always say no information is better than the wrong information. So moving on. So you can see here, this is somebody who has a left ventricular end diastolic area that's probably very small. They're hyperdynamic. Their EF is probably greater than 70%. They're pumping out most of the blood that they're receiving. So this patient is likely going to be volume responsive. This is another patient that would likely be volume responsive as well. Their left ventricular end diastolic area is probably very small if we trace it out, and they have quite significant left ventricular hypertrophy. So they're likely going to like their preload if they present in hypotension. So let's move on to the next parameter, dynamic parameters like fluid challenges. So fluid challenges have been defined in the literature with quite significant variation, but I've picked a few studies that have looked at mini boluses of 100 mils. So when you look at these studies, these are 3 studies that were published that looked at a mini bolus as a predictor of volume responsiveness. And they gave 100 mils of colloid in the first 2 studies, and 100 mils of crystalloid in the last study. And they assessed pre and post aortic, like the first study looked at aortic velocity time integral. And the second study looked at stroke volume variation and pulse pressure variation. The third study also looked at stroke volume variation, pulse pressure variation. And according to their receiver operator characteristic curve, or the ROC curve, they found that a mini bolus of 100 mils is predictive of volume responsiveness. If you take an aortic VTI pre and post and look at the difference, it's predictive with a cutoff of 0.92% being the optimal cutoff for specificity for volume responsiveness. The second study also found a cutoff that was close, 0.91, 0.92, and the third study also found a cutoff that was close according to their ROC curve. So a mini bolus is usually predictive. If you take measurements pre and post, usually tells you whether the patient will benefit from a volume bolus or not. So let's move on to heart-lung interactions. And that is the internal bolus that we spoke about. So we said fluid challenge means an external bolus. Heart-lung interaction and passive leg raise mean an internal bolus. You're giving the patient their own blood. So with regards to heart-lung interactions, you look at one of three things, either the IVC or the SVC or the LVOT VTI. I'm focusing here on ultrasound parameters that indicate that the patient will be volume responsive. So let's review the effective ventilation on left heart filling and right heart filling. So we're talking here about a patient who is mechanically ventilated. If you have somebody who's mechanically ventilated, they will have positive intrathoracic pressure during inspiration. That positive intrathoracic pressure during inspiration in this mechanically ventilated patient will lead to a drop in venous return and a drop in RV preload, and an increase in RV afterload because you're increasing your intrathoracic pressure, so you'll increase your RV afterload. And so with mechanical inspiration, you drop your RV output. On the other hand, with mechanical inspiration, as you breathe in, you actually, as you increase your intrathoracic pressure, you force blood back into the left ventricle. So you'll increase your left ventricular preload with mechanical inspiration, and you reduce your left ventricular afterload. And so you increase your LV output during mechanical inspiration. In expiration, it's the opposite. As they expire, you reduce your LV preload, you reduce your LV output. And so this is very important to keep in mind, that there is an interaction and there is automatically a fluid bolus being pumped to the left heart with each mechanical inspiration. And so, and then to the right heart with each mechanical expiration. What you see on your arterial line is the left heart output. And so let's focus on that. Let's move on and see what you would see in somebody who is likely going to be volume responsive. You will see here likely a variation in your pressure, in your arterial tracing with inspiration, with mechanical inspiration. You will get an increase in left heart output, and you'll get an increase in pressure in your arterial tracing. And then with mechanical expiration, you'll get the opposite. You'll get a drop. And so if somebody is volume responsive, you're likely going to see this variation in your arterial line. And the calculation for that is either pulse pressure variation or stroke volume variation, which a lot of our machines will now show us automatically that number. However, on the other hand, if the patient has adequate volume and their cardiac performance is optimized, you will see that there's likely less respiratory variation in their arterial tracing. But we'll get to this in a second. Why can't I just look at this and just take this as my indicator? There are limitations to this, and we'll go through them shortly. So volume responsiveness, when it comes to heart-lung interactions, can also be assessed using IVC variation, SVC collapsibility, LVOT VTI variability as well. So let's move on. When it comes to heart-lung interactions in a mechanically ventilated patient, the important thing to note is that these variabilities will only be encountered if the patient is in normal sinus rhythm, or will only be reliable. They'll always be encountered, but they'll only be reliable to indicate volume responsiveness if the patient's in normal sinus rhythm. Why do I say that? If the patient's in atrial fibrillation, you'll get variable filling time. As you can see here, there's a diastolic time that's larger between these two R waves, and then a smaller one after, and then a smaller one, and then a larger one after. And so this variability in filling time will lead to a variability in stroke volume and will lead to a variability in your left heart output, your cardiac output, and a variability in your arterial tracing. And so you can get variability from being an AFib on its own. It does not indicate volume responsiveness, just indicates you're in atrial fibrillation. So you cannot depend on this variability in somebody who's in atrial fibrillation. They need to be in normal sinus rhythm. Most of the parameters have also been validated if the patient is getting 8 to 10 mils per kilo of tidal volume, which is not usual in the ICU. Most of the times we try to do lung protective ventilation of 4 to 6 mils per kilo. And in order for the algorithms to be validated for SVV and PPV, you need the patient to be paralyzed and passive on the ventilator, which is, reasonable if you're looking at somebody in the operating room. But a lot of times in the ICU, patients are not usually passive on the ventilator, not usually paralyzed, or a lot of them are on pressure support or in some weaning mode. So when they're passive and paralyzed on the ventilator, you can depend on the pulse pressure variation more reliably. If they're not, then this pulse pressure variation may be due to their efforts while they're trying to breathe in and out. So, as I said, there are limitations. You can depend on pulse pressure variation and stroke volume variation for volume responsiveness if the patient is paralyzed and passive on a ventilator, has 8 to 10 mils per kilo tidal volume, and is in normal sinus rhythm. So let's move on. So what about the IVC? How does the IVC vary with heart-lung interactions? Well, there's been lots of indices that have looked at IVC parameters to indicate volume responsiveness. And you'll hear three terms. You'll hear the collapsibility index, the distensibility index, and the variability index. So what is the difference between these three parameters when you look at IVC variability with respiration? So let's think about it here. When you have a spontaneously breathing patient, the patient at end expiration will have a large IVC. And then once he breathes in with the negative interthoracic pressure, because they're now breathing spontaneously, with the negative interthoracic pressure, the IVC will shrink. And so what you are looking at as your baseline at end expiration is the maximum diameter. And so you put your maximum diameter in the denominator below. And so your IVC max is in the denominator, and then the IVC collapses with each inspiration in spontaneously breathing patient. And so usually we use the collapsibility index in spontaneously breathing patient, and we call it collapsibility index because our baseline, our denominator, is the maximum diameter. And then we're looking at how much it collapses during inspiration. So this is the collapsibility index usually used for spontaneously breathing patients. On the other hand, if you have somebody who's mechanically ventilated, their IVC at end expiration will be small. And then as you give them a positive pressure breath, the increase in intrathoracic pressure will lead to distension of the IVC. And so when you put your IVC minimum diameter in the denominator, and then you're looking at how much it distends during inspiration, during positive pressure inspiration, we call that the distensibility index. And we usually use that in mechanically ventilated patients. So here we said collapsibility index, mostly in spontaneous breathing patients, and you'll take your baseline to be the maximum diameter. Distensibility index, mainly in mechanically ventilated patients, you take the denominator to be your minimum IVC diameter, not your maximum. And then the last one is the variability index, or the IVC variability index. And with that, in the denominator, you put the average. You put the IVC max plus minimum divided by 2. We use that usually in mechanically ventilated patients as well. So this may get a bit confusing, and I will simplify it for you shortly. I'll just tell you what to do, because trying to memorize all these can sometimes be too much. And at the bedside, you just want a quick answer. Should I give volume or should I not? I don't want to spend half an hour trying to understand whether my patient will benefit from a volume bolus or not. So I will try to simplify all this for you shortly. So the dynamic IVC parameters, the patients, when you look at these parameters, they've been validated in patients who are mostly intubated, especially when it comes to the distensibility index and the variability index. Usually these two indices have been also validated in patients who have no respiratory efforts, of tidal volumes more than 8 mils per kilo of predicted body weight. And the fluid responsiveness has been predicted by certain cutoffs. The distensibility index has looked at the cutoff of 18%, and they've found that that is a reasonable cutoff to predict volume responsiveness. The variability index looked at a cutoff of 12%. And an important thing to note about this specific study that published 12% as their cutoff is that 22 out of the 23 non-responders had an IVC of greater than 1.5 centimeters, just an absolute value of greater than 1.5 centimeters. That number we will use shortly. So just to make it simple, look at this. This is the IVC. This is the right atrium. You're getting a subcostal view. The IVC looks like there's huge variation with respiration. And so this is somebody who's spontaneously breathing. And so we're looking at IVC collapsibility with each inspiration. And this is somebody who would be definitely volume responsive, just looking at this just by eyeballing without doing any math. There are some pitfalls that you need to be aware of, and that is beware of the movement in and out of plane, which will exaggerate IVC collapsibility. Beware of the hepatic vein confluence. Try to avoid the hepatic vein confluence. We usually try to measure 2 centimeters from the cavo-atrial junction. Do not mistakenly interrogate the aorta. This is very common for novices who are first learning. They look at the aorta and they call it the IVC. Make sure you're convincing yourself that you're looking at the IVC with the 3 hallmark features of the IVC. Number 1, it's transhepatic. Number 2, it joins the right atrium. Number 3, you see the hepatic vein joining it. And so don't confuse the IVC for the aorta. The IVC falsely increases with RV failure, tamponade, PE, TR, constrictive pericarditis. So all of these are situations where the IVC will be distended. So take, for example, you have somebody with tamponade. Your IVC will be large, but they could still be volume responsive. Because they've got tamponade, they'll actually benefit likely from volume. And so you have to take it in context. And so echo is extremely important. It'll tell you whether you're dealing with tamponade or not. It can be falsely decreased with increased intra-abdominal pressure and with status asthmaticus because of increased patient efforts. So let me get back to what I said. I'm going to simplify this for you as much as I can. And so this is not a real book. This is just a joke. I've not authored a book called IVC Diameter Assessment. This is, yes, my name, but I'm just going to try to simplify it as much as I can. Don't search for this book on Amazon. It does not exist. But it exists in the next 5 minutes. I'm just going to try to simplify the IVC for you as much as I can. So when you look at the IVC in somebody who's mechanically ventilated, as an absolute diameter, if its diameter is less than 1.5 centimeters, and by eyeballing, you see variability of greater than 12 to 18%, by your naked eye, you just see that there's variability that's roughly, that's visible. It's more than, your naked eye can usually pick it up if it's more than 12% or so. And so if you see a diameter that's less than 1.5 as an absolute diameter, and you see variability with your naked eye in somebody who's mechanically ventilated, more than 12%, they're likely going to be volume responsive, very likely, unless they have some other condition like increased intra-abdominal pressure. On the other hand, if you have somebody who's spontaneously breathing and their IVC diameter is less than 1 centimeter and their variability is more than 40%, then they're likely going to be volume responsive. So just memorize these numbers. For mechanically ventilated, 1.5 centimeters, 12 to 18%. Spontaneously breathing 1 centimeter, more than 40%. And that's it. That's really all you need to know at the bedside. So here, just to practice again, we look at this IVC. We see that there's some variability here. This is a patient where I would give volume. Look at these successive images here. We'll start from the left-hand side. We see this is a small IVC. This is likely a patient who would likely be volume responsive unless they have some other condition to cause the small IVC. Look here, this is a patient who has a large IVC, but it has quite a bit of variability. I would still deem this patient to likely be volume responsive if they've got parameters indicating hypoperfusion. What about this patient here? This patient has a large IVC, that has no variation. Is this patient volume responsive? Well, if they've got tamponade, then yes, they'll likely still be volume responsive. So if what's causing this large IVC is tamponade physiology, then yes, this patient still needs volume. But in the absence of tamponade, then maybe not. Now, artificial intelligence is taking over the world. And artificial intelligence is also taking over the world of ultrasound. And so in this day and age, there are certain ultrasound machines that can calculate these values for you. You just need to tell the ultrasound machine whether the patient's spontaneously breathing or mechanically ventilated, and you need to obtain a good IVC view. So this is one of my views here. This patient, we looked at the IVC, and we pressed on a button called Smart IVC, and it automatically showed me the IVC diameter, and I told this machine that the patient is spontaneously breathing. So it automatically knows if the patient is spontaneously breathing to calculate the collapsibility index, and it gave me a collapsibility index of 31%. If I tell the patient, on the other hand, that the patient is mechanically ventilated, if I tell the machine that the patient is mechanically ventilated, then it will not calculate collapsibility. It will calculate a distensibility index and an IVC variability index. So it knows automatically, just by virtue of the fact that you tell the machine that this patient is mechanically ventilated, it gives you a distensibility index of 50% here and a variability index of 40%. So all you need to do is get a good IVC image and press Smart IVC. It'll give you all the numbers. So let's move on quickly for heart-lung interactions, the SVC. So I'm just going to skim over this quickly. SVC collapsibility is usually measured with TE in patients who are passive on mechanical ventilation. If you find a collapsibility of more than 20% with each inspiration, then that is considered the most specific parameter for volume responsiveness. Or a collapsibility of more than 31% is even more specific with 90% specificity, but is not as sensitive, 61% sensitivity. LVOT VTI variability is another aspect where you can look at the LVOT VTI. What do I mean by that? That's the left ventricular outflow tract velocity time integral. Left ventricular outflow tract, LVOT, you can get that from an apical 5-chamber view. And what you want here is to put pulse wave Doppler in the left ventricular outflow tract, just proximal to the aortic valve. And once you put pulse wave Doppler there, what you will see is flow through the left ventricular outflow tract, and that will always reflect your stroke volume. And once you press pulse wave Doppler and you get a tracing, that tracing, you can just basically look at the area under the envelope. Once you trace that envelope, it'll give you what we call a velocity time integral, which is roughly the area under the curve. And so you can see here that LVOT VTI is a surrogate for stroke volume. It actually can indicate how much stroke volume you're seeing. So you put pulse wave and you basically look at the LVOT peak velocity. And if you see a lot of variation in peak velocity, it's like seeing a lot of variation in your arterial line. It's very similar to that. And so if you see a lot of variation in your LVOT VTI peak velocity, that likely indicates volume responsiveness. And that LVOT VTI variability, or LVOT peak velocity variability, is thought to be the most sensitive parameter to predict volume responsiveness. You have more than 10%, it's very sensitive. But also the prerequisites are the same prerequisites you have for your pulse pressure variation and stroke volume variation. You have to be passive on the ventilator, tidal volume more than 8 mils per kilo, normal sinus rhythm with normal intra-abdominal pressure. So here, this is somebody with 24% variability, and so this would be a volume responsive patient. So there are certain pitfalls for this. So if somebody has severe aortic stenosis, you may get an increase in the LVOT peak velocity. Somebody has irregular ventricular rhythm, as I said, you'll get variation. Even if they're not volume responsive, you'll get variation because of the irregular ventricular rhythm. And if they have right ventricular failure, you may get an increase as well. You'll get a decrease, and hence it'll be unreliable with low tidal volume ventilation and with acute respiratory distress syndrome. So again, artificial intelligence has come to the world of ultrasound. All you need to do is get a good apical 5-chamber view, put the pulse wave in the LVOT, and press a button called Auto VTI. Once you press Auto VTI, the ultrasound machine will automatically trace all these VTI envelopes and give you a VTI. Here it's telling us it's 17.3 centimeters. And it's giving us a LVOT stroke volume variation of 0.28, which tells you likely this patient is going to be volume responsive. Get an apical 5-chamber, pulse wave in the LVOT, and just press Auto VTI. Last but not least, in the volume responsiveness section is a passive leg raise. So passive leg raise remains the current gold standard. It is an internal bolus that you give to the patient, a volume of blood that they receive with this passive leg raise. And so how do you do this? You basically get an apical 5-chamber view with echo. You measure the LVOT VTI, as we explained previously, in the semi-recumbent position at 45 degrees. And then you change the position of the bed, not the legs. The position of the bed of the patient needs to be changed to a 45-degree leg raise. As you increase the legs of the bed up to 45 degrees, within 1 minute, you should measure again the LVOT VTI and see if there's a variation in the VTI in the semi-recumbent position versus with a leg raised position. And as I said, this is something that is done with the bed, not by actually physically holding the legs up. If you find an increase of more than 12%, this predicts volume responsiveness. And this is the equation here. You do the VTI max minus minimum divided by the average. And if the increase is more than 12%, this indicates volume responsive, and this remains the gold standard for volume responsiveness. And as I said here, this is not what you should do. You should not be raising the legs like this gentleman is doing. You should be actually doing the bed controls to raise the leg of the patient, because if you raise the legs like this gentleman is doing, you can induce a sympathetic response, and the patient may start feeling it. You may start getting a pain, like the patient may start basically becoming uncomfortable, and that in and of itself will increase your LVOT VTI. And so essentially the right thing to do is to elevate the legs of the bed, not the legs of the patient. So there's pitfalls. The interrogation angle can change, and that can change your VTI. So you need to maintain the same angle. And usually we try to maintain the probe in the same position while you're doing that. But there are certain challenges sometimes with the logistics of moving the bed and moving the legs of the bed up. You need to measure it within 1 minute of leg raise, and that'll give you the immediate response to the internal bolus that you've administered of blood in the patient's legs. If a patient is severely hypovolemic and has no blood in their legs because of their severe hypovolemia, you may not see an increase in VTI because of lack of blood in the lower extremity, because they're just so extremely hypovolemic. So it works well when somebody's hypovolemic, but in extreme hypovolemia, it's not always very reliable. So this is what we went through. We went through the volume responsiveness parameters. We said static parameters are useful, but usually not on their own. Dynamic parameters are more useful. And then the second concept we went through is that volume tolerance means causing harm from giving a volume bolus. And that can be in patients with LV failure, RV failure, somebody with diffuse B-line patterns in their lungs. Last but not least, I'll go through another volume tolerance concept, and that is VExUS. And what I mean by VExUS is venous excess ultrasound. Are the organs congested or not? If the organs are congested, then this patient will likely not tolerate a volume bolus. Before I go to VExUS, I'll ask this question here. Who needs ultrasound? Can't I just look at pulse pressure variation? Can't I just look at everything else? Why do I need ultrasound? Well, you definitely do need ultrasound. Looking at this arterial tracing, yes, you may think that this patient is volume responsive. But you put the echo probe on and you find that this pulse pressure variation is because of a variation in left-sided output, but the RV is actually hugely dilated and in failure. And so in any case of low LV preload, pulse pressure variability alone will not differentiate hypovolemia from RV failure. You can get this exact same picture. In fact, I have seen cases like that where you get pulse pressure variation that is very remarkable on the arterial line. You put the echo probe on, and you found that their RV is huge. This patient does not need volume. If you give more volume to that RV, it will fail even more. And so what they need is RV support. They need something like dobutamine or milrinone or nitric oxide to reduce the RV afterload or inhaled epoprostenol. So they need RV support as opposed to volume. So echo is extremely important because it is the only parameter here at the bedside that is easily available that'll tell you that this pulse pressure variation is because of RV, not because of volume. And so I would say pulse pressure variability and critical care echo must be complementary. They should be used together, not against each other. They should be used together. All right, so let's go on to VExUS. What is the idea behind VExUS? What is the idea behind venous excess ultrasound and the physiology of it? Let's go with a step-by-step approach and then put it all in perspective at the very end. So when you look at the perfusion pressure of any organ in the body, the perfusion pressure equals inflow pressure minus the outflow pressure. Pressure perfusing that organ, or the mean arterial pressure, minus the mean or the venous pressure. And so that will be your perfusion pressure of any organ in the body. You can put in the middle here the like the brain, for example. You see here, what is the perfusion pressure of the brain? What is cerebral perfusion pressure? The equation is very simple. What is the inflow pressure or mean arterial pressure minus the outflow pressure or the CVP or intracranial pressure, whichever is higher. So that gives you the perfusion pressure of the brain. On the other hand, if you replace that with, say, for example, the kidney, what is the perfusion pressure of the kidney? The renal perfusion pressure equals the same, the inflow pressure, which is the mean arterial pressure, minus the outflow pressure, which is the CVP, or the intra-abdominal pressure, whichever is higher. And so the perfusion pressure of any organ equals the inflow pressure minus the outflow pressure. And so what is the issue with the outflow pressure here? If the outflow pressure is high, you may compromise organ perfusion. As you can see, it's part of the equation. If your outflow pressure is high, you will compromise organ perfusion. If your organs are congested, then giving more volume will only increase their CVP or their outflow pressure, and hence worsen organ perfusion. So by giving volume to somebody who's congested, you may actually make things worse. This was very clearly demonstrated in this study that was published in 2020, where they looked at post-cardiac surgery patients and they scanned them. They did a VExUS scan, a venous excess ultrasound in the first 72 hours. And they found that when the organs were severely congested, this was associated with the development of acute kidney injury, even after adjustment for baseline confounders of acute kidney injury and vasopressor and inotropic support. So basically, organ congestion is predictive of acute kidney injury and worse outcomes in the cardiac surgery population. So let's break down the concept even further. What do I mean when I say venous excess ultrasound? It means that there's venous excess. It means that the organs are congested. We examined 4 parameters when we were looking at venous excess ultrasound. The first parameter is the IVC diameter. The second parameter is the hepatic vein flow. We're looking at venous flow here to assess congestion. The third parameter is portal vein flow. The fourth parameter is intrarenal vein flow. And so we're looking at venous flow to assess whether the organ is congested or not. We start with the IVC, move on to the hepatic vein, then the portal vein, then the intrarenal vein. Why can't I just look at the CVP? Again, can we just look at the CVP to tell us? Well, this was actually looked at in a very elegant study where they looked at severe congestion by VExUS versus a CVP of greater than 12. And what they found was that a severe congestion by VExUS was more predictive of acute kidney injury than a CVP of more than 12. Obviously, you get more data points with the VExUS. You look at multiple parameters, the IVC, the liver, the kidney, the intestines, or the intestinal drainage, which is the portal vein. And so you look at multiple parameters with VExUS. So it gives you better information, and it's more predictive of worse outcomes, more predictive of acute kidney injury As you can see here in this leaf plot, the CVP more than 12 is not as predictive as severe congestion by VExUS. So let's try to understand how venous flow normally looks like. We said we'll interrogate venous flow. Back to Physiology 101. Let's understand the basics here. Venous flow is normally continuous. Generally speaking, if you interrogate any vein in the body, normally flow is continuous, unlike arterial flow, which is usually pulsatile. So the only exception to this rule is the hepatic vein. That's the only vein in the body where flow is usually pulsatile. Why is that? It's because the hepatic vein is very close to the heart. Like obviously the SVC and IVC are also very close, and you'll find transmitted pulsatility in both of those. But what I'm saying is the hepatic vein, because it's so close to the heart, you get transmitted pulsatility in hepatic vein Dopplers. But you don't get that in portal vein. You don't get that in intrarenal vein. You'll see that normal portal vein flow is continuous. Normal intrarenal vein flow is continuous. Hepatic vein, however, is pulsatile because it's very close to the heart. And so when you start getting organ congestion, that's when the venous flow starts becoming pulsatile. That's when you start seeing undulations in the Doppler envelope. And so here you're starting to see some pulsatility in the portal vein, which tells me that there's evidence of mild bowel congestion. And here you see more pulsatility, more than 50% pulsatility. That tells me that there's likely severe bowel congestion. So what about the hepatic vein? We said the hepatic vein is the only one out of the parameters that we will interrogate today that has pulsatility. And so what is the normal pulsatility? What is the normal waveforms of the hepatic vein? You have usually the two main ones are the S and the D, systolic waveform, diastolic waveform. But you'll also see A and V. What's more important, as I said, is S and D. These are the ones that are really important. Look at S, look at D. S is usually larger than D in the hepatic vein. But let's break it down. What does A mean? What does S mean? What does V mean? What does D mean? A indicates the retrograde flow that happens with atrial contraction. As the atria contracts, it pushes back blood into the hepatic vein, so you get some retrograde flow in the hepatic vein. But then during systole, during ventricular systole, the annulus of the tricuspid valve moves apical, and you start getting displacement of blood and forward flow through the hepatic vein. And then at the end of systole, you start getting a little bit of slowing, and you get a V wave, which sometimes you'll see, sometimes you won't see. It's not always there. It's due to retrograde end systolic flow from ventricular contraction at the very end of ventricular contraction. And then you get a D wave, which is the antegrade diastolic flow from ventricular filling. And that's when the tricuspid valve opens. So again, let's look at here this diagram. So we look here, this is the S. The S wave is the dominant wave. It's usually greater than the D. And the S wave happens during ventricular systole. The tricuspid annulus is moving more apical, and you're getting blood getting drawn into the right atrium and blood moving in the right direction. So you get forward flow, you get the S wave. Let's move on here. Let's focus on this image here. The next is the V wave. The V wave happens at the end of systole. As blood accumulates, you start getting a bit of a reversal. Sometimes you see this, sometimes you don't. And then the tricuspid valve opens, and you get a D wave. The D wave is forward flow, hepatic vein flow that goes forward to the right atrium. And so, as I said, S is usually larger than D. And then as the atrium contracts, you see here that you will get another reversal. So you got a V reversal and an A reversal. The A reversal is because of atrial contraction leading to retrograde flow back in the hepatic veins. So let's do a step-by-step approach to VExUS. First, you need the patient to be supine. You select a low-frequency transducer, either phased array or curvilinear probe. You can use both. And when it comes to interrogating the renal veins, you want to reduce the Nyquist limit to less than 10 to 15 centimeters per second and increase the color gain. And we'll go through that shortly. Always connect the ECG if it's available. It'll make your life so much easier. If you have an ultrasound machine that has ECG cables, connect them to the patient. It will make it so much better for you. So let's go back to the systematic approach. We will look at the IVC diameter. We'll look at hepatic vein flow, portal vein flow, and renal vein flow. So IVC diameter, that's the first step. So first, we'll look at the IVC diameter, and if it's more than or equal to 2 centimeters, you'll proceed to the next step. If the IVC is less than 2 centimeters, then you stop the examination. It's unlikely that this patient has congestion. Okay, so you start with just measuring an absolute IVC diameter at end expiration. And if it's less than 2 centimeters, no congestion. If it's more than or equal to 2 centimeters, you move on to the hepatic vein Doppler. And so that's step number 1, IVC. And how do you look at the IVC? Well, you get a subcostal or a transhepatic window. You can look at the IVC either in long axis or short axis. You measure it 2 centimeters below the cavo-atrial junction. And as we can see here, the IVC diameter is 2.19 centimeters. So this tells us, yes, you can continue with your examination and see if the abdominal organs are congested or not. We'll move on with the hepatic vein. So the next step is the hepatic vein. How do you interrogate the hepatic vein? From the same IVC view, usually you will find the hepatic vein, either the subcostal or transhepatic window. You'll look at the IVC and you'll find the hepatic vein joining the IVC. It's usually very thin-walled and it drains into the IVC. As I said, you can either be subcostal with your probe or you could be transhepatic in the mid-axillary line. And then you put color Doppler and you'll find flow moving from the hepatic vein into the IVC. And so it's going to be away from your transducer. It's going to be blue. And you apply pulse wave Doppler, usually within 1 centimeter of the hepatic vein. So how does this look like? So here you look at the liver. We see the IVC. And we see here there's a vessel that is joining the IVC right there. This is the hepatic vein. See where my cursor is pointing? As you can see here, there it is. This vessel joining the IVC is the hepatic vein. It's very clear. It's joining the IVC. The portal vein does not do that. And so you look here and you put color on it and it'll be blue. When you see blue, it tells you, yes, this is the hepatic vein for sure. The predominant color here is blue. Blue means away from your probe. When it comes to Doppler, as you can see here, this is the color scale. Blue is away, red is towards your probe. If the flow is moving away from your probe is up here, flow is going down into the IVC, it tells you this is the hepatic vein. So it is a vessel that joins the IVC, and you put color, and you find blue flow. This is your hepatic vein. And just this is a reminder for the convention for color Doppler: blue away, red towards. The BART mnemonic: blue away, red towards. When it's blue, it means flow is away from the probe. When it's red, it means flow is towards your probe. And it's most accurate when you're scanning parallel to the blood flow. So here, this is a flipped image. You can see the liver here very clearly. You can even see the diaphragm. You can see part of the base of the lung, and there's a pleural effusion. But let's look at the IVC. Where is the vessel that is joining? You can see the vessel is right there. I'm pointing at it with my cursor. There's a large vessel that is thin-walled that is joining the IVC. The portal vein, as we will know shortly, is very thick-walled, whereas the hepatic vein is very thin-walled and it joins the IVC. So there it is. This is the hepatic vein. And we put color and you see that there's blue. This is the hepatic vein. Whereas here there is red. This is the portal vein. So this is the hepatic vein, and this is where you want to put your pulse wave to assess the S and D. Okay? As we said, S is larger than D. This is normal. S is dominant over D. Systolic dominance is a normal finding. Here, as you can see, there is an atrial reversal. There's an S wave, and then there's a D wave. Let me just label that. So here it is, S, and then D, and then there's the A. And then S, and then D, there's the A. S, D, there's the A. So S is dominant. So this is normal hepatic vein pattern. So this tells you the liver is not congested. This is normal venous flow in the hepatic vein. And so here S is dominant over D. If you start seeing that the S is smaller than D, you start seeing that the S is blunted. Systolic blunting indicates mild hepatic congestion. And it's so much easier if you have an ECG. You look here, this is the QRS complex, this is systole. You find that the systolic wave is smaller than the diastolic wave. When you start seeing systolic reversal, this indicates severe congestion. If all the flow is diastolic, then there's severe congestion. So this is your second step. The first step is your IVC. Your second step is your hepatic vein. You look at S dominance or systolic dominance. If there's systolic blunting, this indicates mild congestion. If there's systolic reversal, this indicates severe congestion. Next step, let's look at the portal vein. Before we move on to the portal vein, the hepatic vein does have limitations. If you have somebody with severe tricuspid incompetence, this will influence. You'll have systolic flow reversal just because of the tricuspid incompetence. So you cannot depend on it on its own if you have severe TR. If you have severe TR, that you'll get systolic flow reversal. It'll look like it's severely congested. And it may actually be severely congested, but essentially it's because of the TR, not because of volume. And so systolic blunting can be observed also with RV dysfunction, liver cirrhosis, fatty infiltration, hepatic lymphoma, Valsalva maneuvers, abdominal compartment syndrome, or IVC stenosis. So all of these are limitations of hepatic vein Doppler. Let's move on to the next step. What about the portal vein? So the portal vein here is my next step in interrogation. I look at the portal vein Doppler and assess. As we said, most veins in the body, flow will be continuous. And so you're expecting flow through the portal vein to be continuous, not pulsatile. How do you get the portal vein? So you put your probe in the mid-axillary position, and you look through the transhepatic window. You do a slight anterior tilt of your transducer. I find this to be very helpful. Once you see the IVC and the hepatic vein, tilt your probe slightly anteriorly, the patient's anterior. So you're looking at the IVC right now, your probe needs to be tilted anteriorly. And you'll find that the portal vein will be thick-walled and flow in it will be red, away from the IVC, towards your probe. And when you put color flow, as we said, flow will be red towards your transducer. And you apply pulse wave, and you look at the sample gate within the portal vein. Here, as I said, if you fan anteriorly, you see the portal vein. If you fan posteriorly, you see the hepatic vein. So what you need to do is get the IVC in the hepatic vein and then fan anteriorly or tilt anteriorly to see the portal vein. And here we can see both in the same image. We can see here, this is the hepatic vein because it's very clearly joining the IVC and it's thin-walled. Whereas here you see a thick-walled vessel, and this is the portal vein. So the portal vein is up here. I'm pointing at it with my cursor. And if you were to put color on it, you'll see that it's red, flows towards your transducer, whereas hepatic vein flow is usually away from your transducer, going towards the IVC. But here again, we have color, and we see that the portal vein flow is red towards your transducer, whereas hepatic vein flow is blue away from your transducer towards the IVC. So what are the normal patterns? So the normal pattern is that you get continuous flow through the portal vein. The pulsatility should be less than 30%. And what I mean by pulsatility index here is Vmax minus Vmin divided by the Vmax. So the velocity maximum minus the velocity minimum divided by the velocity maximum should be less than 30%. So this slight undulation is normal if it's less than 30%. But if you start getting an increase in undulation, start getting 30 to 50% or 30 to 49% pulsatility, this indicates mild portal vein congestion. If you start getting pulsatility of greater than 50%, as you can see here, this indicates severe portal congestion. And so this is step number 3. Step number 1 was the IVC. Step number 2 was the hepatic vein. Step number 3 was the portal vein. And so you look at if there's increased pulsatility, more than 50%, that indicates severe congestion. 30 to 50% mild, less than 30% is normal. Next step is to look at the renal vein. Or actually, before we go to the renal vein, let's look at some of the limitations of the portal vein Doppler. Slim subjects may have pulsatility even without elevation of the right atrial pressure. Some patients, especially the very thin ones, will have some degree of pulsatility. Doppler findings of congestion may be absent if you have somebody with liver cirrhosis or fatty liver. Liver cirrhosis definitely affect your portal vein pattern. So you may not be able to see pulsatility if they have established liver cirrhosis. Okay, moving on. So the renal vein is my next step or my last step with VExUS. And what you do with intrarenal vein interrogation is that you try to visualize the kidneys with a double density. That's very classic to see this double density in the kidney. You're in the mid-axillary line with your probe with a posterior tilt because the kidney is a very posterior structure. Or you slide back to the posterior axillary line. You use color flow Doppler or power Doppler to identify the interlobar veins and arteries. You reduce the Nyquist limit to less than 10 to 15 centimeters per second. And you increase your color gain to help reveal the renal vessels. And then you apply pulse wave Doppler. The sampling gate will usually catch both the artery and the vein. So what do I mean by this? Let's take a look. So here, this is the kidney, very clear. There's a double density. There's the cortex. There's the medulla. And so this double density tells you this is the kidney. It's very clear. You won't miss it with ultrasound. You put color Doppler, and you start seeing a mishmash of red and blue. You start seeing red and blue together. Or if you put power Doppler, which is more sensitive to flow, you'll start seeing more flow that way. But what I want to emphasize here is that you'll see both red and blue in the same image. And when you put your pulse wave Doppler, you'll likely catch both the red and the blue. The red is usually arterial flow. The blue is usually venous flow because it's away from your probe, whereas red is towards your probe. And so when you put pulse wave, you'll likely catch both artery and vein, which is fine because artery will tell you where systole is. When you see here, when I put pulse wave right in that where the red and blue were together, I put pulse wave there and I reduced my Nyquist limit to 10 to 15 centimeters per second. And what I see is flow above the baseline. This is arterial flow. This is not really what I'm interested in. I'm really interested in venous flow below the baseline. And we can see here that the venous flow below the baseline is continuous. It's not interrupted, and this is normal. And the arterial tracing above the baseline just tells you where systole is. So that is systole, and that is diastole. Systole, diastole. Systole, diastole. Systole, diastole. So this is, you're interested in below the baseline, but whatever is above the baseline will just tell you where systole and diastole is. And try to get at least 2 to 3 consecutive uninterrupted cardiac cycles. What does normal venous Doppler look like? Normal intrarenal vein Doppler looks continuous. Very slight undulation is okay, but normally it's continuous as we can see here. And we're looking below the baseline. So focus here, we're looking below the baseline. Above the baseline is the artery. So the artery during systole, you see flow that is continuous. During diastole, you see continuous flow. This is normal. When you start seeing interruption of flow below the baseline, that indicates mild intrarenal congestion. And that interrupted flow, we call that discontinuous biphasic flow. So normally it's continuous and monophasic, as we can see to the left. In the middle, we can see here that it's biphasic and discontinuous, meaning that you have flow during systole and you have another waveform during diastole. You know that it's systole because of the ECG and also because of the renal artery waveform above the baseline. But below the baseline, you see S and D. This is biphasic discontinuous. When you go into severe congestion, you start losing your systolic flow altogether. All you see is diastolic flow. This is called discontinuous monophasic. It's only diastolic. This indicates severe congestion. So continuous monophasic is normal. Discontinuous biphasic indicates mild intrarenal congestion. Discontinuous monophasic, only during diastole, indicates severe renal congestion. This is the last and final step of my VExUS score, is looking at the renal vein Doppler. And we either say it's normal if there's continuous monophasic, or either say it's mildly congested if there's discontinuous biphasic. We say it's severely congested if it's discontinuous monophasic, only diastolic flow. Intrarenal vein Doppler can be challenging to find. When you're first starting, it's usually the most challenging of the examination to perform. You try to avoid the hilar veins, try to avoid the hilum itself because you may overestimate velocities. And it may not be useful in patients with chronic kidney disease. If they have established chronic kidney disease, then it's usually not very useful. And so here we try to grade it into grade 0, meaning no congestion, grade 1, meaning mild congestion, grade 2, moderate, grade 3, severe congestion. So once you have your exam, you take a look and see, what do I have? No congestion means IVC less than 2 centimeters. That's it. You don't need anything else. Grade 1 means you have an IVC greater than 2 centimeters and any combination of normal or mildly abnormal patterns. If you start seeing mildly abnormal patterns, whether it be in 1 or 2, or even 3, mildly abnormal patterns, we call that grade 1 or mild congestion. So any combination of mildly abnormal is grade 1, mild congestion. If you start seeing one severely congested parameter, only one severely congested parameter, that moves you automatically to grade 2. If you start seeing more than 2 severely abnormal parameters, that automatically moves you to grade 3 or severe congestion. So severe abnormal, severely abnormal, whether it be the hepatic vein, the portal vein, or the renal vein, if you start getting 2 or more that are severely abnormal, that means you have severe congestion. Let's put it all in perspective. What is the evidence for all this? So there's been a few studies that have been published. I won't go through all the literature, but I'll go through some of them. This is a post-cardiac surgery study that has looked at pulsatility in the portal vein and how it predicts outcome. As we said, if there's more pulsatility in the portal vein, if it's greater than 50% pulsatility, that means there's severe congestion. And so what they said here, what they found was that when the portal vein had more than 50% pulsatility, this actually led to longer mechanical ventilation time, longer ICU length of stay, and longer hospital length of stay with significant p-values. So organ congestion matters. Organ congestion leads to prolonged mechanical ventilation, leads to prolonged ICU length of stay, leads to prolonged hospital length of stay. Another study looking at heart failure patients. This is a prospective study where they looked at more than 200 patients with heart failure, and they looked at their intrarenal venous flow. And they divided it, as we normally would, into continuous flow, which is normal, below the baseline, we find continuous monophasic, or discontinuous biphasic, or SMB, as we can see here. This indicates mild congestion, or discontinuous monophasic, or D only, which indicates severe renal congestion. And in the heart failure population, they looked at event-free survival for 1 year, i.e. living for 1 year free from death from cardiac cause or unplanned hospitalization for heart failure. And what they found was that patients who had continuous flow had much better event-free survival. Those who had severe congestion evidence, as indicated by the red line, which is discontinuous monophasic, they had the worst survival, or worst event-free survival. So let me just summarize it's been a long talk and it's late at night, so let me just summarize. I went through volume responsiveness and volume tolerance. And what I covered was the static parameters for volume responsiveness, the dynamic parameters for volume responsiveness. And then when it comes to volume tolerance, I delved into a little bit more detail with VExUS ultrasound. I will summarize and say, when you're examining with ultrasound, dynamic measures are usually better than static measures when trying to predict fluid responsiveness. Passive leg raise remains the gold standard out of the dynamic measures. And it's ultimately your decision based on multiple data streams, whether or not to give fluid. It should be based on multiple data streams, both clinical picture and a combination of ultrasound findings based on your comfort level. None of the bedside measures are perfect tests. Which one you choose to use will depend on both your skill set and the clinical situation. VExUS may help physicians navigate questions around volume tolerance and harm from volume, or the need for decongestion. Knowledge of sonoanatomy, Doppler, and color Doppler is important, and the technical limitation knowledge is important. Higher VExUS scores associated with poor outcomes, both in cardiac surgery and heart failure patients. Interventional studies are still needed to validate VExUS scores. My personal recipe, if you're starting to learn and you're starting to practice, just quickly look at the subcostal IVC, look at variability. Quickly get a parasternal short axis, look at the left ventricular end diastolic area, look at kissing pap muscles. Get an apical 5-chamber, look at LVOT VTI, gives you an idea of the stroke volume. There's variability, they may be responsive. If the lung has B lines, then they're likely not going to be volume tolerant. And then use VExUS if you're questioning whether they're congested or not. And then don't forget examining the RV. The RV is a very important aspect of this equation. I invite you to read this textbook chapter that I helped contribute to in point-of-care ultrasound and the management of sepsis. And with that, I will conclude, and I thank you very much for your time.